It's a privilege for me to be a part of this this symposium. I've been an attendee at it before, and it's really an all-star cast that Dr. Hamid and AIM at Melanoma put together for this. And you know, you may not appreciate it, but these people that they have talking to you are really outstanding leaders in the field, and so it's great. But you could get a sense, I think, that they were, as they were up here talking, they were their minds were operating on this really high level, right, and trying to translate into normal speech, and you know, and it's tough to do. So I have the advantage of being a surgeon, and so that is a very simple-minded specialty. You know, can we cut it out? Yes, we can cut it out. Okay, let's cut it out. You know, it's pretty straightforward. So I'll hopefully have that as an advantage as I make my presentation. So in terms of thinking about surgery as a treatment for metastatic melanoma, certainly in many medical circles, this is thought of as a little bit crazy. And so we don't all have our meetings in Vegas, but this is actually a surgical meeting that I'm not a part of, but for bariatric surgery. And the title of the session is Bariatric Surgery Gone Wild. And when you talk about surgery for metastatic cancer, a lot of times it's thought of as kind of a wild concept as well, but hopefully I'll be able to show that it's not totally crazy. So they're really thinking about it. There are two goals that you might have for surgical operations in the context of metastatic cancers in general and melanoma specifically. One is as palliation, and the goal there is to improve quality of life or get rid of symptoms that patients are having related to a specific tumor. And then surgery is therapy, and the goal there is to actually extend the length of life as a result of surgical intervention. So palliation, what does that mean practically? It means that if there's a specific tumor that's causing a problem, if it's painful, if it's a mass that's bleeding or infected, or if it's causing a bowel obstruction, then you can intervene with a targeted therapy of surgery, take out that problematic tumor, and then the patient can go on to feel better or have a better quality of life. This is often actually a very challenging thing to figure out, who is an appropriate candidate for a palliative operation. So if you operate to try and relieve pain, obviously surgery causes pain in and of itself, so it's a matter of figuring out where the balance is. Bowel obstruction for melanoma is a particularly specific area of interest because we found that in some melanomas, the melanomas express this thing on their surface that actually targets them to go to the bowel, to a specific area of the bowel. And so what can happen is if this is a tumor, this is the intestine, the tumor can arrive and form a lesion on the bowel, and then the bowel is normally moving food down along in that direction. And what happens is it mistakes the tumor as a piece of food and starts to try and move it down the intestine. And eventually this intussusception, it's called, gets in there and blocks off the bowel. And what that looks like in real life is this, where you have a loop of the intestine, and then you can see these points where it has sort of telescoped into itself. And that's from a tumor down here that's pulling that part of the bowel in there and blocking it off. So we can take out that part of the bowel and put it back together again, and then that obstruction is fixed. So that's one instance where you can palliate, you can improve quality of life by taking specific tumors out. But what about surgery as therapy, as actually something where we're going to take out a tumor and hopefully that will extend the patient's length of life? And here's where it gets a little bit heretical, because it's often thought that it's too late at that point for surgery to help, because surgery is a local therapy and this is more than a local problem. It's also potentially morbid and complicated to do some of these operations, and so the usual thinking about this is that surgery for metastatic disease has a very high risk-benefit ratio. But that may not actually be the case. So why do I say that? Well, if we think about surgery for earlier stages of melanoma, surgery actually cures the vast majority of cases of melanoma that are diagnosed in the country every year. So for stage 1 melanoma, more than 90% of patients have surgery, cured forever. For stage 2, it's probably in the neighborhood of about 80% that are cured forever. And even in the setting of metastatic melanoma, where it has spread from the original site where the tumor started, many of those cases are cured just by surgery alone. You take it out and that's the end of it. And so if the metastatic melanoma is discovered in a sentinel lymph node, it's the majority of those patients probably that are cured. And even in the setting where there are grossly replaced lymph nodes, larger lymph nodes that have melanoma in there, many of those patients are also cured just by surgery alone. So this is just one of those survival curves that you've seen, and this is basically just a number of patients that are alive at any given time over the follow-up. And so these are all patients that had lymph node metastases, and this is a trial that's looking at a whole different thing. But basically you see that for patients that have just microscopic amounts of melanoma that is spread to the lymph nodes, most of those patients are cured. And for patients even with, in this group, they had tumors that you could actually feel or see, many of those patients cured by surgery alone. And this is in an era where there were none of these great drugs that you've heard about were around, really. There wasn't really anything that did a whole lot of good other than the surgery part of their treatment. So surgery can cure, can help some patients who have metastatic melanoma even by itself. And this is in comparison to the old systemic melanoma therapies that were not as great as all of this stuff you've been hearing about today. And so what this is a statistician's analysis of all of these phase 2 clinical trials that were done in cooperative groups of different types of systemic medical therapies for melanoma. So what this is the percent of patients in these studies who are alive at 1 year into their treatment. And this is the size of the trial, how many patients were in the trial. And what they've done then is just based on these probabilities, the statistical analyses, they've calculated out these confidence intervals of what would be kind of an average survival that you might expect. And what you see in each one of these dots then is a trial, and they compare the size of the trial to how many patients were alive in the trial at a year. And the take home is that every one of these trials falls within these confidence boundaries. Basically what that means is none of these trials were better than any of the other trials. And what that means is that probably none of the trials actually did anything useful. And so this is kind of the context that all of these specialists that you've heard from today entered into this very, very challenging, discouraging field. And what they've done is they've changed this situation to where it's much, much better now than it was then. But this is the context where you sort of think of surgery as maybe not so crazy a thing to do when our other alternatives were not that great. So these are just two of the examples of the drugs that you've heard about that have been recently approved, that have made real benefits. This is that PET scan that Dr. Boasberg showed you, where it went from tumors everywhere to switching off the switch and the tumors are all turned off. This is the Yervoy or ipilimumab data, the first trial ever to show a survival benefit in advanced melanoma, so really breakthroughs and tremendous advances. So where does that fall on this scale? So these are statistically invalid curves that I have just eyeballed and put on here to make these other trials fit on here, but these are all those old trials. And then if you look at the new trials, this is where they fall. Ipilimumab, the different ipilimumab trials, the vemurafenib trial, so well outside of those confidence intervals, clearly making a real difference in terms of how people do. But let me show you a few other examples of outcomes in melanoma. And so these are all trials in which patients had surgery for metastatic stage 4 melanoma. And in all of those trials and all of those series, they fall outside of the confidence intervals as well. This is an unfair, invalid comparison, and I'll show you why. But it does at least give you some encouragement for that selected patients, surgery may be a reasonable thing to do. So surgery's gotten better over the years as well. As you heard, medical therapy is getting better, surgery has gotten better as well. We're better able to detect tumors and detect all of the tumors that are there, so you make the discovery of metastatic disease earlier on, and you know where all of it is, so you know better which patients are actually candidates to have all of it taken out And you'll see that having it all taken out is a very important component of deciding whether or not surgery is helpful. We also have new capabilities and better surgery overall. So CAT scanning, we're all familiar with CAT scans, and essentially what you have with CAT scans is they take pictures of sort of slices of the body, and this is a state-of-the-art textbook example of a CAT scan from 1990. And this is these are the kidneys, this is the spine, this is the liver, this is the pancreas, and I don't know, they have an arrow here pointing at something in the pancreas. I don't know if you can make it out, but it's a little bit challenging given the resolution of this CAT scan. So if you move ahead a few years, not worrying about what's specifically on the scan, you can just look at the level of detail that you can see. You can begin to see little individual blood vessels within the liver. The details of all of these things are much better. So our ability to see smaller tumors has gotten better. And so we'll move ahead a few more years to a scan from 2008, and the scans are even better. So the level of detail, the size of these tiny little tumors that you can see in the liver, it's really remarkable. So our ability to identify the disease and really be able to decide an appropriate treatment plan is much better now than it was and continues to get better. We have other better imaging modalities. We have ultrasound we can use in the midst of an operation. MRI scans add in many cases in terms of specifically in melanoma. And then PET and PET-CT scans have added another level of our ability to fully stage patients and identify all of the tumors that they have. So the stage 4 disease that we talk about now may be a different situation than what stage 4 melanoma was back in the days of the earlier trials. We also have better surgical tools to be able to take out and treat tumors that we couldn't deal with before. So I've tried to make these a little less gory, these pictures, but this is an example of a surgical stapling device, and this is during a liver resection. And so what the staplers look like is this, and so what happens is these jaws close together on something you want to cut. They fire multiple rows of staples on either side, and then there's a knife actually in here that cuts in between. So it's a way of rapidly getting through, in this case, a liver resection with relatively minimal blood loss and better outcomes. This is what's called an argon beam coagulator. This is actually a stream of argon gas that's flowing out from the tip of this instrument, and it's carrying an electrical current, again, to a cut surface of the liver to stop bleeding there as well. And then there are ablation tools as well. So if you can't take it all out, there are other ways of treating things. So this, again, is a liver, and this is a probe, a radiofrequency ablation probe. It actually cooks the tumor, and another version of it looks like this. It comes in here, it has multiple prongs that come out, and then there's a current that's applied at a specific frequency that cooks the tissue around it, kills it definitively, so you don't actually have to take it all out. So patients who aren't candidates to have everything taken out can still have all of these individual lesions treated in a focal way that will definitively kill them. Another way that's being done now that you're familiar with, it's not surgery, but it's a similar sort of concept. This is radiation. And so radiation can be applied in a way that is very, very focused, almost like surgery. And so this is what's called a cyber knife. And these are plates that are used in something called IMRT. And the concept here with this kind of radiation is that you give many, many little beams of radiation. And so as they pass through the normal tissues, there's very little radiation that interacts with those tissues. But all those tiny little beams come together in exactly the same spot. And so you can get very, very high doses, lethal doses of radiation into a very tightly defined area. And so it's essentially like radiation surgery. And this can be done, and it's done in many cases in patients with melanoma for brain metastases. You leave the normal brain alone, you kill the tumor very definitively. So these are localized treatments that can kill individual tumors with relatively modest side effects for the patient. So the operations are getting better, the downsides of the surgery are less, and with these new tools, lesions that we couldn't approach in the past, we can now approach relatively safely. Why is that important in terms of thinking about surgery as a therapy? Well, if you cause harm with the treatment, you're never going to have an advantage for the patients. This is a different study from a different disease, gastric cancer. And what this study was, they compared two different types of operation. One where you take out a whole bunch of lymph nodes around the stomach, In other words, you just take out a few lymph nodes around the stomach. The thought being, the more lymph nodes you get out, the better these patients will do. And when you look at the two different types of surgery, this is the bigger operation, this is the smaller operation, there's no difference, right? But if you look carefully at these trials, what you see is with the bigger operation, they had a whole bunch of people, an excess of people that died probably as a result of complications from the surgery very early on. And with that, you're never going to show a difference between the two. If we get rid of that operative-related mortality, the curves look very different. And so it's very important as you contemplate whether you're going to operate on someone who has metastatic disease that you can do it safely. Because if you can't, then it's not worth doing. So this has been done in melanoma for a number of years and at multiple centers around the country, and these are just a number of series that have been reported in the literature, some from the John Wayne and some from other sites. And as opposed to what had been the standard survivals for metastatic melanoma, which unfortunately were in the 5% range, these all showed substantially higher rates of survival over long term. A prospective study was done through the Southwest Oncology Group, a cooperative group that shows essentially the same thing. A substantial fraction of patients, even out at 5 years, who are doing fine just with the surgical intervention. And then the largest study really that's been done that's looked at patients who've had metastatic stage 4 melanoma that's been surgically resected was a vaccine trial that was coordinated out of the John Wayne. It was Don Morton's Canvaxin vaccine. And that eventually went through these final phase 3 trials to see if it showed a difference versus a placebo. And as you can see, it didn't. So the trial didn't show that the vaccine itself was an advantage. But forgetting about the difference between the two arms, what you'll notice is that this study, stage 4 melanoma back in the era where there weren't good systemic therapies, at 5 years, 40% 5-year survival. So that's really good for metastatic melanoma. And we don't know exactly why these results are as good as they are. There are a bunch of different potential factors that go into it, but surgery as a therapeutic intervention may be one of them. Was it just the patients that had very favorable tumors that did that well? No. So these are patients that have relatively what you think of as favorable, just skin distant metastases or lymph node distant metastases, and they do very well, but also the patients that had internal organ metastatic melanoma also did quite well with nearly 40% surviving at 5 years. So it's not just the most favorable patients. Did it matter if it was just a single lung nodule or a single metastasis versus if there were more than one? It made some difference, but actually not as much as you might expect. So patients even that had 4 or 5 lesions that were taken out, still a decent number of them had a long-term favorable outcome. So why was the survival so good in this trial? Highest survival ever reported for a prospective study in metastatic melanoma. And it may be that they were just favorable patients to begin with. So if you're a candidate for surgery, it's likely you have less melanoma, it's likely you'll do better over the long term. So that may be a big part of why these patients did as well as they did. It's also possible that this BCG, which is a non-specific immune stimulant, had a positive effect as well. It's never been looked at in this dose, in this context, and we've seen in other contexts where BCG is effective as a treatment for metastatic melanoma, so it's conceivable that that had a positive effect as well. But it may very well be that surgery in and of itself was beneficial to these patients. Getting rid of these metastatic tumors was helpful to them. So who should have surgery? Not everybody, that's for sure. And particularly given the way that the field is evolving and the great advances in systemic therapy, you really have to be careful about who it makes sense to operate on. We know who does relatively well with surgery, so that's an easier question to answer when we look back at patients we've operated on, who's done well and who's not done well. And one of the factors is how fast the tumor is growing, so the tumor volume doubling time. And if the tumor is growing fast, then those patients are likely to develop new disease even after you've taken out all the disease you could see on scans. And they're probably not great candidates for surgery unless you can intervene with a medical therapy, slow their tumors down, and then potentially take out whatever's left. You have to take it all out. So these are different series of resections in different parts of the body. So resection of lung metastases, of spleen and adrenal metastases, liver metastases, and bowel metastases. And you can't see what each of these curves are, but I'll tell you that in each one, when all of the tumor has been taken out, those patients do better, survive longer, have a better chance than if any of the melanomas left behind, where you don't seem to make much difference relative to not operating on them at all. So you have to be able to take it all out, which is why those scans and being able to find all of the tumors is very important. This is all of the sites combined, and it's the same sort of thing. And so this is a quote from my mentor, Don Morton, who is responsible for all of these long-term studies. From this paper was, there is no survival benefit to leaving disease behind, and that is for sure the case. Other selection factors that seem to be associated with good outcomes with resection of metastatic melanoma. One is if the patient has not had previous lymph node metastases. So for some reason in that circumstance, they do better after surgery for their distant metastases. The longer the interval in between when they were originally diagnosed with the melanoma and when they have the surgery to remove the metastases, the better they will do overall. And then where the metastasis is has some degree of influence on how well they do after the surgery. And when you put all those things together, in terms of a multivariate analysis, the things that come out, younger patients tend to do better. If they don't have the intervening lymph node disease, they do better. And if they have longer periods of time in between the diagnosis and the surgery, they do better. So overall, I think there is a real role for surgery, even with the new drugs in metastatic melanoma. It's a matter of patient selection and choosing the right operation. How often is this possible? We don't really know the answer to that question. And in different parts of the world, there are very different results on how many patients are actually candidates for surgery. In our own sentinel lymph node study, when we looked at patients who eventually recurred with distant metastatic melanoma, about 80 to 85% of them actually only had a single site involved. So potentially it could be a very high fraction of patients that are potential candidates for surgery. In other countries, in the Netherlands, they've looked at this and they find almost no patients who are candidates for the surgery at the time that they present. And it may be a difference in the amount of follow-up patients have. There they have somewhat of a minimalistic approach to not scanning and things, whereas in the US we're much more aggressive about following people closely so that we can intervene at an early time point. Who's an appropriate candidate? We don't really know that for sure. And what's the future of this given the advances in these other medical therapies? And I think there are sort of two possible ways of thinking about how this might interact with these new effective systemic therapies. And one is with surgical consolidation. The other is with what you might call surgical sniping. So consolidation would be for patients that have had one of these medical therapies and have had a response or stable disease with the therapy, but they still have things that are left. And so in that case, is there an advantage to consolidating that by removing whatever's left? And we don't know the answer to that question, but theoretically there might be. And then sniping would be someone who's responding to a medical therapy, but either has a mixed response, and there are a couple of tumors that are getting out from under control of one of these drugs, or they've responded and then they've started to grow again in one or two of these things. And then surgically, or with radiation or what have you, we could potentially target those sites, get rid of those troublemakers, and let them continue on with the effective therapy that's working in all the other sites. So sniping and consolidation might be things that we'll have to look at as we get these new drugs for effective therapy. So thanks very much for your attention. It's great that, to have been here. A quote from John Wayne I think that is appropriate for all of you, but thank you.